So we're going to be looking at some of the ethical challenges in refugee and immigrant care. And I use refugee as a general term in some spaces. Most of the folks that we do work with are resettled refugees. I'm going to talk about language, that even the term refugee can be complicated, and can actually do a disservice depending on who we're working with. I'm going to talk about the clinical and systemic barriers, moral distress, and then some tools, guidance, some background that I've been utilizing, philosophical foundations that are actually have been worthwhile and applied to these situations. And so, just a little bit of background. There's over 117 million forcibly displaced people worldwide. And I'm not talking just the UN's definition of refugee, but individuals that have been displaced due to war, famine, natural disasters, oppressive communities. And so it's mounting. Every day I see articles of another boat that has turned over, of refugees trying to come into safety, or some um, unexpected disaster that is happening because people are needing to be free. 40 to 50% of refugees are under the age of 20, which is alarming. And this isn't because simply families have large families, but a lot of times you will see single parents where a parent has died, or a parent is back in a war-torn country. And so there's a lot of underage individuals that are traveling, and traveling some great distances. I've known refugees coming up through the US-Mexico border that had traveled from southern Brazil, with kids as young as 3, 4, 5 walking. 60 to 80% of refugees have untreated PTSD. There's a variety of different data out there. The range is 60 to 80 depending on the studies. We need more research to get some more definitive answers. And I wouldn't be surprised if it's even actually higher than that. And then 2 to 3 times of higher suicide risk versus the general population. And so this is something to keep in the back of your mind as we progress through this. So, United Nations definition of refugee is it's limiting. It's owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, political opinion, outside of the country of their nationality, and unable to, or owing to such fear, and unwilling to avail himself to the protection of that country. And there are so many individuals left out of this definition. And I'm putting this definition here because when it comes to policy, and not just within the US, but globally, oftentimes policy is driven by how we define individuals and populations. And it can be quite limiting because not everybody who actually has the need are included. And so the folks that are left out, um, individuals that have been through natural disasters, climate changes that have really wiped their communities clean. Evacuees and quote unquote guests, where they have temporary protected status. And oftentimes, where you see this term guests, it's because of an acute military way of evacuating people from a country, a location, a specific location within a country. And then you have the undocumented persons fleeing violence. They are not identified as asylum seeking. They're not qualified to have that particular title based on policies or definitions. And then, for those of you who've been in prior sessions with me, victims of trafficking. And I spoke about that in previous sessions. And so the current US context in particular is damaging. quite frankly. There are executive orders restricting refugee admissions, asylum seeking admissions, expanded deportation operations, reduced resettlement caps, and even reduced financial support for those individuals who had secured some financial support as they resettled. And the mounting fear and avoidance of healthcare is exponential. And every single month, every single year, it's getting to the point where it's putting not only populations and communities in jeopardy, but the providers that are trying to care for them. So when we look at immigration threats as mental health determinants, there's several policy and legal uncertainty. I've done some qualitative work with healthcare providers as well as leadership within NGOs. And so in looking at those populations, there's fear of deportation, the ongoing chronic stress, as one example, the lack of temporary protective status, or when we do have temporary protective status, it becomes obsolete in some communities and not others. So there's an injustice there. Examples of some healthcare access barriers, definitely language and translation gaps, and this is an ongoing threat. Um, Discrimination from providers and institutions. I put in one of the quotes from our qualitative research that's coming up, where colleagues are fighting with other colleagues and questioning whether and why undocumented individuals or even resettled refugees that are seeking citizenship, or even some who have citizenship, have been denied or have been discriminated within healthcare settings. The cumulative trauma burden is exceptional in a way that I don't think we realize the magnitude of trauma that does not come to light in the clinical encounter, or even within communities where you have leaders and elders of that community trying to draw out and create safe spaces. I've been talking with some of our resettled Bhutanese populations where leaders that have been in our community for 20, 30 years have said that suicide is increasing, unhealthy dietary habits are increasing, and it has been a challenge even working, you know, within the communities themselves, that they're part of the culture. And then the cultural and social isolation, community fragmentation. We definitely saw the isolation during COVID, but that isolation has remained. There have been pockets, families that just simply are afraid, and they're afraid not only of the threats to their health by being in new environments that they're not used to. I was earlier on when I was coming and talking to Nicole, I'm like, my allergies are killing me. I have a refugee patient that was really struggling and did not understand allergies and thought that they were doing something wrong, that they were committing a quote unquote sin, and that their feelings of being congested and having headaches was their fault. And so getting down into understanding cultural perspectives of even just basic symptoms as allergies is really critical. There is also discussion about the loss of cultural healing practices, where even though we're trying as a community to build bridges, to develop our relationships, to ensure that families and populations are able to have their grocery stores and restaurants and things that are meaningful, and using the foods and the clothing and the tapestry that is meaningful to them. One of the comments that I continue to hear is that the Western medical perceptions have very much dominated. And not complementing or allowing room for more of the cultural healing practices of various groups. And that's coming up more and more, particularly in some of the ethics consults that I've had at various hospitals. So, getting into more of the mental health conditions that often go undetected, PTSD, like I mentioned, is at the top of the list. Depression, anxiety disorders, psychosis, and schizophrenia, oftentimes misdiagnosed or underscreened, in part because there's a view that what the patient is experiencing may be a remnant of their trauma, of the PTSD, or a cultural symptom, if you will. I've heard the term cultural symptom, which is in itself very unique. It'd be interesting to have a discussion about that and then the meaning of that. But I've heard patients, resettled refugees say, we've been treated as though we have cultural symptoms. And then substance use disorders, which in beyond substance use disorders of your traditional alcoholism and addiction, drug addiction, some communities are seeing heightened gambling issues, addiction in terms of gambling addiction, sex addiction, sugar, addictions to sugar, and so it's beyond just what we see on the surface. And so, why do these conditions go undetected? Western screening tools often lack that cultural validity. We don't seek to understand those cultures in the first place. Obviously, stigma, mental health is taboo in many, many cultures. Some cultures won't even admit that there's something called mental health. Language barriers, fear of disclosure, definitely learning disabilities, health literacy added to that, lack of training. And even though I've seen improvements, especially in primary care environments, we still do not even understand the depth and breadth to which these individuals have experienced their life trauma. So. So here's a case that has been particularly disturbing to me that remains in my mind quite often, especially working with a variety of different Latina families. Maria Morales and her children, Leah, age 4, and Hector, age 11, sought asylum. And I met this family in Matamoros, the US-Mexico border. And her husband and eldest son were brutally murdered by gangs in Guatemala. And Maria's family, the maternal side of her family, are indigenous, and her husband's side of the family was down in, city life, used to that. So her culture, even within Guatemala, was quite a shock when she moved to the city from a very rural indigenous population. And so Maria and Leah both experienced sexual assault during their journey from Guatemala to the U.S.-Mexico border. Her children both were taken at one point during a quote unquote refugee, an unauthorized refugee camp. She was able to retain her children for basically offering sex. Hector also suffered a traumatic machete injury. His fingers were removed with serious infection, and she thought his life was going to end. So, and he had the infection. It was pretty bad when one of the NGO doctors actually saw him for the very first time in several months. And then the initial refugee status was actually denied. Um, Despite the fact that they had medical evidence, they were traumatized. They were moving from a country, one of the Northern Triangle countries, in which asylum-seeking individuals are typically at least identified as, yes, you are a refugee by definition. Um, their accounts were deemed not credible, despite the fact that both Maria and Leah had sexual trauma, physical sexual trauma that was documented, and her son missing his fingers. So after NGO legal guidance, and so I just want to call out that I love the NGO doctors out there. Some of the communities that are coming together. I was with Catholic Charities at one point, but the legal guidance, a lot of our lawyers in the United States will help and pro bono and do as much as they possibly can. And so there was a NGO lawyer fresh out of law school that was helping this family, and they successfully were resettled in rural Maine. Um, Going from Guatemala to Maine is a big culture shock, right? Not only going into very, very much English speaking Maine, but also in an area that climate, their resources, everything completely different. And so just keeping in mind this particular case of the trauma that they experienced, but also the trauma that could emerge by moving into a completely different culture, especially a culture that may not be accepting of this family. So I don't know what happened. They were put on a bus. They were given a bag of for lunch, sandwiches and coats that were donated through Catholic Charities, and then they went off to Maine. So just thinking about them constantly of that type of family and this family specifically. So our providers, not just the individuals in our hospitals and our clinics, but providers, even in, the NGOs that are trying to do their best. There's oftentimes conflict between personal values, institutional compliance. Uh, the biggest thing that I've heard over the past 18 months is cooperation mandates. That has come to fruition in many of the formal clinical settings, and I'll get into that. Systemic inadequacy, especially right now, there's a reduction of resources. Talking to folks at Asia Inc. and some other agencies that we work with heavily in Akron and Cleveland area in particular, just the amount of funding that has been declining. Witnessing without intervening, exposure to that severe trauma, those torture survivors, the children separated from families, the trafficking, and without the means or resources to understand those root causes or fearful of understanding those root causes. And then that professional isolation, the lack of those internal support systems, peer supervision, communities such as even I Echo, where people could come together, talk about these things, and have that space. We need more of that. So, in collecting some of the voices through qualitative research, just in the past 2 years has been eye-opening. And here's just a snippet. I presented this at actually the research at a couple of pediatric hospitals because they were interested in the providers and what is this situation doing to the people that are trying to help. So one pediatric hospitalist said, "This hospital really sucks. They expect me to comply with ICE, expletive no." And that was after a policy came out that said basically, give them, hand over the medical record, hand over, the families, etc. This was not in one of our local hospitals, by the way. A psychiatric nurse, this 12-year-old patient needs more inpatient care, but they cannot afford it and their medical resources are limited. We're being forced to discharge, and I'm inclined to say they are suicidal. So basically, the nurse was like, I want to keep them here. I want to keep them safe, and I'm going to lie and say that they are suicidal just to keep them safe. And so the as you can imagine, the moral dilemmas are there. One social worker says, "I want to quit, but I can't because I need to be strong and help. I'm so tired, no fatigue. I can barely keep it together when I hear these stories." And then one family medicine physician in our local area said, "My colleagues keep thinking only quote unquote real citizens deserve our care." And it's just been eating away at our physicians, our social workers, nurses, and they're traumatized. They're traumatized by the situation and definitely have a desire to help. but oftentimes don't have the support to do so. Some of the ethical tenets that I bring to the table, as a justice theorist, as a humanitarian, I've been really focusing on Martha Nussbaum's work. She is also a justice theorist. She took what was our understanding of basic human rights to a different level, as well as understanding that we need to shift our view from disability to what we're capable of, our capabilities. And she had a foundational set of 10, everything from life to bodily integrity to emotions to play. These are the things that are foundational to every human being. And when we deny any one person the opportunity, it's not to say that we have to give, you know, resources deliberate, but it's the opportunities that we're expected to provide. If we are denying opportunities, we are not just violating simply human rights, but we are actually denying a person's ability to flourish and to become a citizen of this world without the political um, setting of like, oh, this is what a quote unquote real citizen is, or this is what the legal term is. She wants us to step away and say, we need to view people as people and not simply some label based on constructed ideals of a particular society or a breakdown of society. And so the capabilities approach is something that I reference quite often in the work that I do. Some of you have heard this multiple times, but it really does come to tuition and it aligns with our trauma-enforced care. And I know many of you are working in this domain, or trauma-informed care rather. And so the capabilities do align quite well, whether we're talking about bodily integrity and the right not to be trafficked, for example. We can see trauma-informed care frameworks aligning with that. So safety, trust, transparency, empowerment, peer support, and so forth, cultural humility, cultural sensitivity. And it's the trauma-informed care framework that says, here's the emotional impact that can help a human flourish, in addition to those capabilities that Martha Nussbaum has pointed out. The 10 pearls specific to refugee and immigrant care, these are the 10 pearls that align with the capabilities approach that use trauma-informed care to guide us. And so here are the 10 pearls that some of our researchers, our clinicians have come up with. So practice a strengths-based approach. Ask what your patients are proud of and not just what went wrong. And I would extend to even providers. What are you proud of and not just went wrong in that patient encounter? Promote consistent, trusting relationships. Assign the same provider interpreter whenever possible. The one thing that I really appreciate a lot of agencies and smaller clinics is that you have that continuity of care. Where I see communication breakdown, relationship breakdown is with medical teams in hospitals, where I see patients and families feeling alone because here's one attending doctor this week, and then another the second, and another the third, or another the fourth, even. And while it can be a challenge, we're on call and there's variability of being on call. I've made it a mission that I will stick with a family, even though it's not my week, for example, as a clinical ethicist. And it's because of this. These are the lessons that I want to live by. Recognizing trauma impact on the developing brain, especially with, I mean, if we have so many kids and young adults that are in this situation, we need to recognize, how can we help that development? Using a three generational approach. Parental PTSD affects the child, or the grandparent affects the parent and the child. So treating the whole family is key. Recognizing that trauma may not end after migration. And this is the biggest lesson that I've had to really just learn from folks and families, that that trauma lingers. And even if one has quote unquote healed, in many ways, some other trauma triggers, like moving to Maine, may occur. Creating an immigrant friendly environment, having translated materials, having interpreters, utilizing interpreters. Don't rely on family caregivers that are supposed to be caring for their families and not translating and interpreting for a provider. Ask permission before discussing trauma. Often use the "would you like to share your journey" and keeping it open. And that trauma will come out, but it will come out when they're ready. And then treating trauma appropriately, culturally adapted interventions, narrative exposure therapy, as I would say. Know the local resources. I try to make sure that my medical students, my graduate students, know the agencies in our backyard, know the people who can help. Or at least try to help. And if they don't have the answer, they're willing to find out, and then advocate for those patients yourself. Coalitions, groups like this are so key. And so I asked for an integrated ethical framework where we integrate the capabilities approach, that community-centered ethics of communitarianism, and then, of course, that narrative approach, honoring that story, honoring the individual, and recognizing that the capabilities and the beauty of families and individual that can help them flourish through the challenging times. And so, some pragmatic actions for mental health practitioners, from a clinical assessment standpoint, using the culturally validated screening tools, asking permission, the things that I've mentioned before, combining mental health care with cultural healing practices. Honestly, combining mental health care in every aspect of care. It really needs to be integrated. Community and advocacy. Suicide prevention efforts, we really need them. In our community particularly, and I'm preaching to the choir here, you guys are probably seeing an exacerbated level of suicidal ideations. And we definitely need those prevention efforts to be understood, and lay persons, like myself, that are not physicians, I want to know more. I want to be there, because if I'm having an ethics consult, for example, or I'm teaching a student who comes from a resettled refugee family, I want to learn more about those suicide prevention efforts. And then, of course, that provider self-care. Like I mentioned, the the nurses, the social works that are like, I'm fatigued. I'm having to navigate a very challenging waters with ICE policies. And so just watching out for each other, or that family med doc that says, my colleagues don't even treat our own patients in our small clinic with the dignity and respect. And so that provider self-care is key. So, my ethics in action, for those of you who don't want to go into the theory and Nussbaum and all of that, um, these are just my tidbits. Immigration threats are mental health threats. Policy is clinical. Moral distress is real. Recognize the capabilities of your patients, not just the deficits. Trauma-informed care must be equity-driven and community co-designed. Early, consistent, culturally humble care prevents crises, and advocacy is a clinical responsibility. That systems that harm patients need fixing. And so I quote Nussbaum at the end here: to protect human dignity, we must ask what each person is actually able to do, and most importantly, to be. So. These are my selected references. I have so much more. And if you guys are interested in getting into the more philosophical to the more pragmatic, I'm happy to share those with you. So Thank you. Here's my contact information. If you're doing research, clinical care, if you want to reach out or just have a safe space to talk, I'm here. So thank you.